Yes, sir.
Okay. So you can start, sir. Yeah, please. Dr. Muralidharan and Lakshman Swami, please start.
Yes, sir.
Good afternoon, sir. Muralidharan, sir. Good afternoon.
Good afternoon, sir. Good afternoon.
Okay, sir.
Yeah, take over, please.
Good afternoon, sir.
Start
Good
now.
afternoon,
A 7-year-old male child, Master Dinesh, hailing from Erode, whose informant is his mother, whose reliability is good, came to the hospital with the chief complaints of weakness of lower limb and frequent falls for past 2 years.
Okay, this is going to be a neurological case, right? At
Yes,
the
sir.
end of the presentation, you are going to answer me 3 questions. Is there a neurological lesion? The question number 1. And question number 2, if it is a neurological lesion, where is the lesion? And question number 3, what is the lesion? Right? I am
Okay,
expecting your answers after your case history now. You can continue.
Yes. History of presenting illness. The patient was apparently normal before 2 years. Then he developed history of weakness of lower limb for past 2 years, which was insidious in onset, progressive in nature, no aggravating factors, no diurnal variation, not associated with pain. History of frequent falls for past 2 years. History of difficulty in climbing stairs for past 2 years. History of difficulty in getting up from sitting position for past 2 years. There was no history of numbness. No history of fatigability on routine activities. No history of constipation or cold intolerance. No history of diarrhea and heat intolerance. No history of fever. No history of body pain or rashes or joint pain. No history of trauma. No history of headache, vomiting, and visual disturbances. No history of involuntary movements or fasciculations. No history of loss of weight and loss of appetite. No history of prolonged immobilization. No history of breathlessness, chest pain, and pedal edema. No history of recurrent respiratory infections. No history of walking on toes. Eye system examination. No history of altered sensorium. No history of slurred speech. No history of abnormal sensation of smell. No history of visual disturbances. No history of double vision or abnormal eye position. No history of chewing difficulty or loss of sensation of face. No history of difficulty in closing eyes. No history of any deviation of angle of mouth or drooling of saliva or loss of taste sensation. No history of hard of hearing or giddiness. No history of difficulty in swallowing or hoarseness of voice. No history of difficulty in turning head or any difficulty in protruding tongue. No history of stiffness or flailness of extremities. History of thinning of thigh muscles present. History of difficulty in climbing stairs. History of difficulty to sit up or rise up from sitting position. No history of difficulty in rolling over. No history of difficulty in raising head. No history of difficulty or inability in lifting hands above the head. No history of difficulty in writing, mixing foods or buttoning shirts. No history of dragging of food. Able to perceive warm and cold during bathing. Able to feel own dress. History of pain after injection. History of waddling gait. No history of tremors or involuntary jerking movements. Able to walk in straight line. No history of bowel and bladder incontinence.
One second, doctor. Hello?
Sir?
Actually, what is the progression, doctor? Actually, you told the onset.
Yes, sir.
But I want to know the progression.
So it was gradually.
Fall for 2 years, no? Is there any,
Yes, sir.
any regression in the milestones?
No, sir, there was no regression.
Walking may not be able to walk, or running may not be able to run. So that to rule out degenerative disorder, that is very important, no? For the past 2 years, frequent falls okay. Was it progressing? There is more frequent falls now compared to before 2 years.
Yes, sir. It was progressive, sir. It was increasing, sir.
No, that you have to mention here. You have not mentioned about that. It's very important to know, because to know it is static lesion or a progressive lesion like degenerative disorder or any thrombosis, hemorrhage, embolism, they will improve. Due course of time, they will improve. So that is very important, no?
Yes,
any
sir.
neurological disorder, onset progression is very important. Onset is acute or just in the case of thrombosis, hemorrhage, and embolism, there will be paralysis slowly they will improve. But in the case of degenerative disorder, they will be regressing. A child which is able to walk or run may not be able to walk initially. After 6 months, they will not be able to stand at all. Then slowly they will not be able to sit with support. Then they will not be able to roll over in the bed. So they'll regress like that. So that progression is very important because it's for 2 years now.
Yes, sir.
I want to know the outcome 6 months. So that will give a clue whether it's a degenerative disorder or a static disorder. In a cerebral palsy, it will be static. So that is very important. No onset progression, that is very important. Okay. So just to mention, try to mention those things.
Okay, sir.
Well,
Okay.
and what you have said not associated with pain. What is the importance of that statement?
Sir,
No, actually, in DMD, Duchenne muscular disability, there will be no pain.
Yes,
So that point is very important. No pain. If there's no pain, then you have to think of myopathy also. Particularly Duchenne muscular dystrophy, there will be no pain. Okay.
yes, sir.
Okay. Go ahead, doctor. Go ahead.
Past history: no history of epilepsy, tuberculosis, bronchial asthma, or diabetes mellitus. No history of exanthematous illness. No history of previous surgeries. No history of chronic steroid intake. No history of dog bite, and no history of ear discharge.
Previous slide. Here we have missed one important thing, Melvin. What is this? History of similar illness in the past.
Yes.
Right? If you have a history of similar illness of weakness, inability to use the limbs, extremities, and he recovered. Now again, if you are getting like that, what do you think of? Periodic paralysis. So that is the entity called as periodic paralysis. So in any past history, the first statement should be regarding history of similar illness in the past.
Okay, sir.
Continue.
Antenatal history: booked and immunized case, registered case, first order pregnancy, regular antenatal visits, iron and folic acid taken, first, second, and third trimesters uneventful. No history of decreased fetal movement.
One more point. Go to antenatal history. Doctor, one more point here you have to say is the history of polyhydramnias. If you think of any myopathy, there will be difficulty in swallowing. So they will develop polyhydramnias.
Okay, sir.
So that will help in congenital myopathy and all. There will be difficulty in swallowing and will associate with polyhydramnias. So I feel you can mention that point.
Okay,
If you are discussing, if you are thinking of myopathy, then think of polyhydramnias also. And decreased fetal movements. Okay, that's okay. Okay.
Natal history: normal vaginal delivery at 37 weeks of gestation, institutional delivery, birth weight 3 kilograms, no prolonged second stage of labor, cried immediately after birth. Postnatal history:
Who cried immediately after birth, man? Baby cried immediately
baby
after birth.
cried.
Continue.
Postnatal history: breastfed within half an hour of delivery, no history of NICU admission, fast urine within 3 hours of birth, fast meconium on day 1, no history of jaundice, cyanosis, seizures, or aspiration in the neonatal period.
Sir, any history of difficulty in sucking?
Sir?
Feeding difficulties.
Breastfed within
Sir
half
is
an hour,
asking
that's
about.
okay. But
No,
no,
sir.
have any feeding difficulty? That
No,
you have
sir.
not mentioned. See, actually, in such cases, no, there may be difficulty in sucking or swallowing. Also, the duration of sucking may be more. So, in such these cases, I feel you can just mention those points.
Okay.
Okay, what
Okay,
are
sir.
any difficulty in sucking for a prolonged period, and difficulty in swallowing. Aspiration also like complication. There can be just regression of the food because swallowing. No? So that point you can just elaborate in such cases. Okay.
Okay. Okay, sir.
Okay, go ahead. Go ahead.
Developmental history: gross motor development. Attained gross motor developments are appropriate for the age. So I have to.
So 1 second.
Shall I tell?
Go back. Go back. Why you are not mentioned about the head control? Because loss of head control is the important point in case of any myopathies, no? That will be earliest feature.
Yes, sir.
So in the case, when it develops is very important.
Okay. Fine motor development.
So mention head control, okay?
Okay, sir. Fine motor development. Attain fine motor milestones are appropriate for the age. Social adaptive milestones. Attain milestones are appropriate for the age. Language milestones. Attain language milestones are appropriate for age. Diet history. Expected calorie intake is 1,540 kilograms according to Holiday-Seeger formula. Observed calorie intake is 1,450 kilocalories. Calorie deficit is 90 kilocalories. Calorie deficit in percentage is about 5.8%. Protein. Expected protein intake is 26 grams according to ICMR recommendations. Observed protein intake is 25 grams. Protein deficit is 1 gram. Protein deficit in percentage is about 3.8%. Immunization history. Immunized up to date according to National Immunization Schedule. Last vaccine is OPV second booster and DPT second booster at 5 years. Family history. Child born out of non-consanguineous marriage. History of similar illness in maternal uncle, second degree relative. Socioeconomic history. Thatched house, 2 rooms, 3 members, water source bowel, father's occupation plumber.
1 minute, go for the previous slide. Go for the previous slide. Hello, doctor. Go to the previous slide, doctor. Immunization.
Oh, okay.
Okay. See, doctor, now immunization. Because after how many days after the immunization, the child develops the weakness. That's an important point. There are some vaccines also in the demyelination.
Yes, sir.
Okay, you told 7 years and boost at 5 years.
Yes, sir.
So exactly, you are saying following the immunization, you are getting that weakness. Okay.
Yes.
So in that case, you just see if there is any relation between the last dose and that. Okay.
Okay.
The immunization is given on January 5. The child developed a weakness by January 15. Then you have to think of any correlation. So in such cases, better to be more specific. Okay.
Okay, sir.
Okay. Go ahead.
Father's occupation is plumber and his educational status is up to 10th standard. Latin was absent. According to modified Kupusamy scale, child belonged to lower middle class family, class 3, score 11. Allergy history.
1 minute, doctor. 1 minute. 1 minute. Hello.
Dr. Lakshman sir, audio
where
break
is the area there belongs to that? Because lead poison.
Dr. Lakshman sir, உங்க ஆடியோ அப்பப்ப பிரேக் ஆகுது பாருங்க, செக் பண்ணிடுங்க.
Hello.
Yeah, கண்டிப்பா இப்போ ஓகே, கண்டிப்பா பண்ணுங்க.
இப்ப கேக்குங்களா?
Yeah, good. Yeah.
Hello.
Yeah, proceedங்க. Yeah, proceed.
இப்போ lead poisoning you have to think, doctor. Lead poisoning. Any battery, any petroleum. So lead poisoning can present with neuropathies.
Okay, sir.
So the area from which they are coming is very important in this case. Okay.
Okay, sir.
Okay. Good. Good.
Allergy history, no history of any allergy to food or drugs. Contact history, no history of contact with tuberculous patient. Summary. A 7-year-old male child with complaints of progressive weakness of lower limb and frequent falls for the past 2 years, associated with thinning of thigh muscles, difficulty in climbing stairs, and difficulty in rising up from sitting position without support. History of similar illness and a second-degree relative. I would like to proceed with CNS examination.
So, is there a neurological lesion?
Sir, no, sir.
Is there a neurological lesion?
Sir,
Why
the
you are
problem
saying no?
seems to.
Neurological means entire central nervous system.
So no, sir. There was no any no history of any neurological problems, sir, according to the history, sir.
This is a part of neurological problem. Is there a neurological problem? A child can come with complaints of difficulty in walking due to orthopedic problem, due to rheumatological problems. So here is this belonging to neurological. Here the history points towards a neurological problem. And where is the problem?
Sir, it is focused to the muscles, sir.
Okay, let us confirm with the examination.
Yes. General examination. The child is alert, conscious, and oriented, not dyspneic at rest, not pale, not icteric, no cyanosis, no clubbing, no generalized lymphadenopathy, no pitting pedal edema present, no signs of dehydration, and no neurocutaneous markers present. H2 examination. Tongue normal, shoulder depression in the posterior axillary fold, valley sign present, BCG scar present on the left deltoid region, spine, exaggerated lumbar lordosis present, no kyphosis or scoliosis, genitalia, both testes are descended, thighs, thinning of thigh muscles, leg, calf hypertrophy present, and there was no contractions.
What is the differential diagnosis for calf muscle hypertrophy? Is it real hypertrophy or a pseudo hypertrophy?
Sir, here it's most commonly pseudo hypertrophy, sir.
What is the difference between a true hypertrophy and a pseudo hypertrophy?
So in true hypertrophy, the power of the muscle will be normal or more, sir. But in pseudo hypertrophy, even though it looks like a hypertrophy muscle, the power of the muscle will be very less.
Good. What is the differential diagnosis for calf muscle pseudo hypertrophy?
Sir, Duchenne muscular dystrophy, sir.
Yes.
And hypothyroidism, sir. Hoffman syndrome or Kocher-Debré Semmelagny syndrome.
Okay.
And parasitic infections, sir. There will be swelling of the calf area, sir. Like
bilaterally, it's most probably unilateral.
Oh yes.
Okay. And amyloidosis.
Yes, sir.
Why you have mentioned hypertrophy, doctor?
Sir?
Why you have mentioned hypertrophy? Was the power normal or more?
So I didn't examine the power until now, so I just saw the calf.
You just mentioned calf muscles are enlarged.
Okay, sir.
This gives impression that there is a power is more.
Okay, sir.
Okay, you better don't commit here.
Okay, sir.
Continue.
Yes. Vitals, pulse, rate 95 beats per minute, regular in rhythm, normal in volume, no specific character, no vessel wall thickening, No radial delay or radiofemoral delay. Blood pressure 100 per 70 mm of mercury measured in right upper arm in sitting position. Respiratory rate 18 breaths per minute, abdominal thoracic type. Temperature 98°F measured in right axilla. Anthropometry. Height, the observed height was 117 centimeter, but the expected height was 109 centimeter. Interpretation, it is between 25th and 50th centile. Inference is normal. Weight, observed is 21 kilograms. Expected weight is 22 kilograms. Interpretation, it lies between 25th and 50th centile. It is normal. Body mass index, observed is 15.3. Expected is 15.1. Inference, it's normal.
Students, kindly take note of this. Next slide. Take note of this new chart for the body mass index. Here you need not use that formula weight in kg divided by height in meter square. Directly you can mark the height and the weight, and you can get whether it is overweight or an obese child. This new BMI tool for rapid assessment is being introduced recently. Next slide. And this is a new growth charts. It's a combination of previously we were using the up to 5 years we were using WHO growth charts, and 5 to 18 years we were using the IAP growth charts. In the recent growth and development conference, the man, the image, Dr. Mohammed Kadilkar, is have done pioneering work in the achieving the in estimating the norms for Indian children. They have released the new growth charts, combined WHO and IAP growth charts. With the right side, the vertical column, it is for calculating easily identifying the mid-parental height. On the left top, there is the body mass index tool. So if I get a soft copy for this, I will distribute to the students. Continue.
Systemic examination, higher function. Patient was conscious, oriented to time, place, and person. Patient is able to recall recent and remote events. Speech, nasal tone is present. Language, comprehension good. Expressive language appropriate for age. Cranial nerve examination, olfactory nerve, test for smell. On both nostrils, able to perceive. Optic nerve examination, visual acuity, near vision on both eyes, it was N6, which is normal for the day. Distant vision, 6/6 in both eyes. Field of vision, normal in both eyes. Color vision, able to differentiate colors in both eyes. Fundus examination, not done.
You could have done a
Oculomotor
fundus
nerve,
examination, no?
sir?
You could have done a fundus examination. Because it's a neurological case, it can be degenerative disorder. Is there any cherry spot, anything is very important, no, doctor? I think you could have got an optal opinion, no?
Yes.
Okay, when you present next time, fundus exam is very important.
Okay, sir.
Okay.
Oculomotor nerve, trochlear nerve, and abducens nerve examination. Pupil size, normal in both eyes, normal and equal in both eyes. Light reflex, direct light reflex, present on both eyes. Indirect light reflex, able to elicit in both eyes. Extraocular movements, equal and full in all directions in both eyes. Accommodation reflex, present in both eyes. Ptosis, which was absent in either side. Trigeminal nerve examination. Motor examination, clenching of teeth, able to perform, and movement of jaw, able to perform. Sensory system examination, touch sensation over the face, able to perceive on both sides. Reflex, corneal reflex, able to elicit on both sides. Conjunctival reflex, able to elicit on both sides. Jaw jerk,
In a case of neuromuscular weakness, what is the importance of examining this extraocular movements and involvement to find out whether they are involved or not? What is the importance of identifying the facial muscle involvement?
Sir, you can differentiate from neuromuscular junction problems and myopathy, sir.
Very good.
So and also in some myopathies, there will be a predilection for involvement of ocular muscles.
ocular muscles and facial muscles
Yes,
also.
facial.
There is a faciomuscular,
Facioscapulohumeral
humeral
dystrophy.
dystrophy. They all tend to involve the facial muscles, and in myasthenia, as you said, myasthenia gravis also they have a predilection for involving the facial muscles.
Yes,
And
sir.
in a variant of GBS, Miller-Fisher variant of GBS, extraocular muscles will be involved. So, in a case of neuromuscular weakness, you have to give great attention to look for the involvement of extraocular muscles, facial muscles, and pharyngeal muscles.
Okay, sir.
Continue.
Facial nerve examination, motor part, wrinkling of forehead, able to perform, closing of eyes, able to perform on both sides, nasolabial fold, present on both sides, blowing of cheek, able to perform, deviation of angle of mouth, absent on both sides, sensory part, taste over the anterior two-thirds of the tongue, able to perceive on both sides, and vestibulocochlear nerve examination, vestibular part, nystagmus, absent,
Which is the
cochlear,
muscle? Which is the muscle in the face not supplied by facial nerve? Which muscle in the face is not
the
supplied?
levator palpebrae superior,
Good. By blowing of cheek, which muscle is being tested?
buccinator.
Buccinator. Good.
Doctor, how do you test the antibody of tongue? Taste.
Sir, asking the patient to close the eyes, sir.
Okay.
Yes, sir, and opening the mouth. I will test the anterior two-thirds of the tongue on right side and left side, sir. Giving some of the taste that the child knows to express.
There are how many tests? There are how many tests? Taste.
Sir, salt,
Okay.
sweet,
Okay.
bitter, sir. Sour.
Okay.
So,
Sir,
There are 5 tests, doctor.
yes, sir.
Sweet, salt, sour, bitter, and what is the 5th thing? Umami. The recent concept is 5 taste sensations.
டாக்டர் லட்சுமணசாமி நீங்க 2 சிஸ்டம் ஆன்ல இருக்கு உங்களுக்கு.
அப்படியா?
ஆமா பாருங்க உங்களுக்கு எக்கோ அடிச்சிட்டே இருக்கு.
இப்ப ஓகேவா?
ஓகே ஓகே. குட் சூப்பர். நல்லா இருக்குங்க. Yeah, proceed. Hello? Hello?
Sir? Well, Melvin, you have to tell where you will test for the taste sensation, tip of the tongue, sides of the tongue, where there will be specific areas for testing the specific taste sensation. There are.
Yes, sir. Bitter taste sensation posterior one-third of the tongue, sir.
Hello? Where is this sweet?
Sir, tip of the tongue, sir.
Salt?
Sides of the tongue.
Okay, continue.
Cochlear part, Rennie's test. Air conduction is more than bone conduction.
Is it dorsal?
Sir?
It is in the posterior part of the tongue, doctor.
Yes, sir.
It is tested by the posterior part of the tongue.
Okay, sir.
And it is not by any food or food substances. It is by doing galvanic current.
Okay, sir.
Okay, that's what you remember. Okay. Okay, go ahead.
Cochlear part, Rennie's test. Air conduction is more than bone conduction, and it's normal on both sides. Weber's test, not lateralized to any side. Glossopharyngeal nerve and vagus nerve. Gag reflex present. Position of uvula present in midline. Pooling of secretions absent. Spinal accessory nerve. Shrugging of shoulder, able to perform. And turning of head to the opposite side, able to perform on both sides. Hypoglossal nerve, protrusion of tongue, able to perform and not deviated. Fasciculation and fibrillation absence.
You don't say vesiculation in tongue. You say only fibrillation, right?
What are previous slide? Hello?
Sir?
Go to the previous slide. 8th now. Vestibular part, how to test that? What are the tests?
Sir, caloric test, calorie test, sir,
Okay.
and
But you are not performed. Okay, it's okay then.
sir, Romberg's test, sir,
Very good. Romberg, then
and Utenberg test, sir.
tandem walking.
Tandem walking, sir.
And then Utenberg test.
Yes, sir.
That I will at least mention there. It is easy to do.
Okay.
Okay, just try to mention it. Okay, thank you.
Okay. Motor system examination. Bulk of the muscle, upper limb, mid-arm circumference 12 centimeter on both arm, and mid-forearm circumference 10.2 centimeter on both sides. Lower limb, mid-thigh circumference was 25.2 centimeter on both sides. Mid-calf circumference was 27.5 centimeter on both sides. Tone, upper limb, both sides was normal in tone, but lower limb, hypotonia was present on both sides.
What is tone? Define tone.
The partial residual contraction present in the muscles, or resistance offered by the muscle to the passive movements.
Okay. What are the tone abnormalities? You know.
Sir, hypotonia and hypertonia.
Hypertonia and hypotonia. Okay. Continue.
Power, upper limb, shoulder, extensor, the power was 3/5 on both sides. Flexor, 4/5 on both sides. Abductor, 3/5 on both sides. And adductor, internal rotation and external rotation were all 4/5 on both sides. Elbow, extensor, 4/5 on both sides, and flexors are also 4/5 on both sides. Wrist, extensor, extension, flexion, adduction, and abduction were all 4/5 on both sides. Lower limb, hip, extension was 3/5 on both sides, and flexion was also 3/5 on both sides. Adduction and abduction.
Can you explain how will you test for extensors of the hip?
Sir, extensors of the hip. Sir, I will patient in the prone position, sir.
Good.
Yes, sir. Then I will ask them to lift their legs, sir.
Okay.
And I will see whether they do against gravity or not. So if they can't do it against gravity, I will ask them to lie in an lateral positions, decubitus positions, sir. Then I will ask them to move the legs, sir, whether they can extend
Move the
the leg
limbs
on.
backwards. Yes.
Yes, sir.
Okay. Good.
Adduction and abduction were both 3/5 on both sides, sir. In the knee, extensor and flexor are both 3/5 on both sides, sir. Ankle, plantar flexion 4/5 on both sides, and dorsiflexion also 4/5 on both sides. Reflexes, superficial reflex, conjunctival reflex present on both sides, corneal reflex was also present on both sides, abdominal reflex present on both sides, chromastic reflex present on both sides.
You have
Plantar
missed
reflex.
anal wink reflex.
Yes.
It's very important in case of neuromuscular weakness, where you have identified tone abnormalities in lower limbs, right?
Okay.
So in any neuromuscular cases, especially when the lower limbs are more involved, you have to look for the anal and urethral incontinence,
Okay.
sphincter functions, right?
Okay. Plantar reflex, plantar flexion on both sides. Deep tendon reflex. Bicep jerks were grade 2 on both sides. Tricep jerk was grade 2 on both sides. Supinator jerk was grade 2 on both sides. Knee jerk was grade 1 on both sides. Ankle jerk was grade 3 on both sides.
What is this grading of deep tendon reflexes?
For grading,
Can you tell us the
grade
grades?
0 is absent, sir. Grade 1 is sluggish, but can be produced using reinforcement. Grade 2 is normal, sir. And grade 3 is brisk when compared with knee jerks, sir. We can compare it with knee jerks, sir. Grade 4, there will maybe clonus or very exaggerated reflex.
Okay, good.
extrapyramidal system examination. No history of involuntary movements, no history of tremor. Sir, shall I proceed, sir?
Sorry, is asking some questions, man. You wait. Sir,
Hello?
questions, sir?
You said is angle jerk is exaggerated here.
Yes, sir.
How do you explain that?
Sir,
Knee jerk is decreased, doctor. Ankle jerk is engaged.
yes, sir.
It will be very difficult for you to explain.
Okay, maybe grade 2 only, sir.
Yes.
Normal ankle jerk.
Maybe grade 2 could have committed as grade 3.
Yes, sir. You have to mention it as grade 2, Melvin.
Okay, sir.
And in Duchenne muscular recording, you can go back and check again.
Yes.
Okay, sir. Extrapyramidal system. No history of involuntary movements, no history of tremor, no history of abnormal posture. Cerebellar function test, finger nose test, able to perform on both sides. Finger
Cerebral
test.
functions normal, right?
Yes, sir. Cerebellar function. Waddling gait alone is present in gait.
Waddling gait is not part of cerebellar
Yes,
gait. No?
gait.
What is the cerebellar gait? It's called as
Ataxic gait.
ataxic gait. What is the other name for waddling gait?
Trendelenburg gait.
Trendelenburg gait. Okay. Continue.
Don't commit like this, doctor. Don't commit waddling gait.
Okay.
Okay.
Sensory system examination. All the sensation, both the dorsal column sensation and anterolateral column sensation, were able to perceive, sir, on all the areas. And robo test was negative. Tactile localization, able to localize the site. Stereognosis, able to identify the object.
So sensory system is absolutely fine.
Yes, sir.
Okay.
You just mention as cortical sensations differently.
Okay, sir.
You don't mix it, doctor, like this. You just say cortical sensations, and you can mention everything, no? Tactile localization, 2-point discrimination, stereognosis, and tactile extinction. Those things you can mention separately as
Okay,
cortical sensations. Okay. Sorry.
Okay. Autonomic system. Bowel and bladder habits normal. Bladder not palpable. No perspiration. No signs of meningeal irritation, and spine and cranium were normal. Other system examination. Cardiovascular system. First and second heart sound heard and it's normal. No murmur. Apex peak felt at left fifth intercostal space, medial to the mid-clavicular line. Respiratory system. Normal bronchovascular breath sounds heard. No added sounds. Abdomen soft, not tender, and no palpable mass. Specific examination. Gower sign positive.
Can you explain Gova's sign?
Sir, the patient is asked to sit down on the floor, sir. Then we'll ask them to stand up, sir.
Without
He
support,
will just climb on himself, sir. He'll try to straighten the knee using his hands. Sir.
Oh, initially he will getting up from sitting position. He will support with his upper limbs. He will support keep his upper limbs on the floor, and he will lift his hip, and then he will climb on himself. He will keep the upper limbs on the knee, and then he will try to stand up. So they may not be able to straight away stand up from the sitting position.
Summary. A 7-year-old male child with complaints of progressive weakness of lower limb for past 2 years, associated with thinning of thigh muscles, difficulty in climbing stairs, difficulty in raising up from sitting position without support, and has similar illness in a second degree relative. On examination, there is nasal tone, pseudohypertrophy of calf muscle, and atrophy of thigh muscles. Power of shoulder, hip, knee, and ankle joint muscles are reduced. Knee jerk is diminished, and ankle jerk is exaggerated.
Ankle
Cranial
jerk
nerves,
is normal.
ankle jerk is normal. Cranial nerves, sensory and cerebral system are normal.
Okay. What's your diagnosis?
The case of X-linked inherited muscular dystrophy, probably Duchenne muscular dystrophy, without congestive cardiac failure, contractures, and no lower respiratory tract infection.
How will you clinically differentiate between one of the first differential diagnosis is Becker muscular dystrophy?
Yes, sir.
How will you clinically differentiate between Duchenne muscular dystrophy and Becker's muscular dystrophy?
Sir, first, the age of onset will be in Duchenne muscular dystrophy around 5 years of age, sir. But in Becker's muscular dystrophy, it will be around 8 to 10 years of age, sir. And the progression of Duchenne muscular dystrophy will be rapid when compared to Becker, sir. They will be wheelchair bound by 10 years or around 13 years of age, and they will usually die within 20 years of age, sir. But in Becker muscular dystrophy, they may die up. The life expectancy is about fourth decade or fifth decade, sir. And we can rule out Becker muscular dystrophy in this case specifically is because maternal uncle is no more, sir, for this child, sir. In Becker muscular dystrophy, he will be alive more than 20 years of age, sir. But
we cannot rule out with that history, right? We may not exactly know what are the complications of DMD.
Complications of DMD, respiratory failure, sir, and aspiration or lower respiratory tract infection, and cardiomyopathy, sir. Ankle contraction. Yes, sir.
What type of cardiomyopathy, sir?
Dilated cardiomyopathy.
Dilated cardiomyopathy. So in some children, there is no correlation between the severity of cardiac illness and the severity of neuromuscular weakness. So in some children, they may get severe cardiac problems before they become wheelchair ridden. They may die early. So just because his maternal uncle died early, we cannot come into the conclusion that it cannot be a DMD. DMD cannot be ruled out because the genetic lesion they have the same focus. They are involved in XP21. The same locus is involved in both the diseases. So we can rule out Duchenne Becker muscular dystrophy only after investigations. Clinically, we cannot with the history of early demise of his maternal uncle, we cannot rule out BMD.
Okay.
You said what the age of presentation is 5 years in DMD. What are the early signs we can suspect DMD? Early signs of DMD.
Sir, poor neck control, sir.
Good.
Sir, there may be delay in attaining gross motor developmental milestones, sir.
Some delay may be there.
Yes, sir.
Subtle form of hip girdle weakness may be there. The weakness may occur at onset, may occur at 4 or 5 years, but the child may be attaining the lordotic posture at 2 years itself. Lordotic posture to compensate for the gluteal weakness, right?
Yes, sir.
And some children they do present with Goversen at earlier age. What are the differential diagnosis for hypotonia and neurodevelopmental delay in general? Any child presenting with hypotonia and the neurodevelopmental delay?
Sir, cerebral palsy, atonic cerebral palsy.
Atonic cerebral palsy, good. All cases of neuromuscular weakness, hypothyroidism, good. Your endocrine disorders.
Yes, sir, and storage disorder.
Inborn errors of metabolism. And it can be also a manifestation of a protein energy malnutrition, or it can be a manifestation of a chronic illness. It has been a side effect of a secondary problem to a chronic illness. So hypotonia and a developmental delay, it is a very broad differential diagnosis. You have to be carefully examining the child to rule out the neuromuscular problems, right? How will you manage this, sir?
Sir, I will try to keep the child as ambulation as far as possible, sir. And I will give
Management
nutrition.
means investigation.
Multidisciplinary.
First
Investigation. Sir, for diagnosis, I will in muscle biopsy and blood PCR, sir. And there may be elevated serum creatinine.
So screening test. You start with the screening test, right? It's not very easy to do a right straight away. You cannot do a muscle biopsy. You need some good neurological center for that.
I will look for serum creatine kinase, sir.
What is the normal serum creatine kinase level?
Around 160. 160 units per liter.
International units.
Yes, sir.
What is the level of serum creatine kinase in case of DMD?
So about 15,000 to 35,000 international.
Very high, very high.
Yes, sir.
So if you suspect a neuromuscular Duchenne muscular dystrophy, and if you are doing a serum CPK, a normal CPK or a mild elevation in CPK is almost against your diagnosis of DMD, Duchenne muscular dystrophy, right? Very high. Yes, it should be in 10,000s. Okay. Good. What are the other organs in the body which secrete creatine kinase?
Brain and
good. Cholama.
Brain and heart, sir.
Brain and heart. So you have to mention it as CKBB for the creatine kinase from brain, CKMM for the creatine kinase for the muscle, and CKMB for the heart, right? And we can also test this carrier state in females using the creatine kinase, right?
Yes, sir.
Okay.
In advanced cases, you have low enzymes now when all the muscles are destroyed.
Yes, sir.
And in that case, there's an exception. So that you remember that point. Yeah.
Okay, sir.
In advanced cases, when there's most of the muscles are damaged, the enzyme levels can come down.
What inference you will get in electromyogram?
Sir, I can differentiate between muscular problem and nerve pathology, sir, if there is any nerve pathology.
Okay, it's a denervation pattern, or a myopathic
Yes,
pattern. Okay. But it may not be very useful in diagnosis of DMD. And electromyogram is very difficult to carry out in children. It needs cooperation of the patient. They have to make voluntary contractions, and they have to relax the muscles at our command. So it is very difficult in children, right? What is the tell me about blood PCR?
Sir, polymerase chain reaction, sir. We can identify the genetic defects using this problem. The chromosome, X chromosome, sir, in locus short arm 21, we can identify deletions or duplications or some other mutations using PCR.
Can you identify all the cases? Can your PCR identify all the cases of DMD? 100%?
Sir,
it's only 60 to 70%. Still 30% of DMD children,
sequencing,
they can have a normal PCR. So if your PCR is positive, it's okay. But your clinic, it is when it is not correlating with your clinical picture, and if your PCR is positive, if PCR is negative, you have to think of false negative, and you have to go for muscle biopsy.
Okay.
The muscle biopsy will give you 100% diagnosis, and especially if you make dystrophin, specific dystrophin immunocytochemistry, it will give you the exact differentiate. You can differentiate between a Duchenne muscular dystrophy and a Becker muscular dystrophy, depending upon the dystrophin levels. In a classical case of Duchenne muscular dystrophy, the dystrophin protein in the muscle biopsy specimens will be less than 3% of normal. So it's a very, very low, less than 3% of normal. In a Becker's muscular dystrophy, either the dystrophin size, protein size may be decreased, or the protein size may be normal, but the quantity is decreased. Like that, you can differentiate between a DMD and BMD using the muscle biopsy specimens. And you can also prognosticate when the child will go for a wheelchair ridden, depending upon the other proteins like sarcoglycans, murosins, depending on the presence of other sarcolemmal proteins. You can it also has a prognostic value, right?
Okay.
What type of genetic? It is all hereditary. You are more frequently saying about his maternal uncle. It's all it's a mandatory. Is it mandatory to be the hereditary disorder? Does all the mothers of DMD children need to necessarily to be a carrier?
No, sir. It can also be a sporadic mutations.
Good. 25 to 30% of cases are still there as a sporadic mutation. So we have to think about if there is a family history or a elder sibling is affected like that, the diagnosis will be easy. If there are no such history is possible and his mother's CPK levels also normal, we have to think about sporadic mutation. In such cases, muscle biopsy is very mandatory. You have to do muscle biopsy to diagnose Duchenne muscular dystrophy in such a scenario.
Okay.
Where you do muscle biopsy in DMD, doctor?
Sir, we can do in deltoid, sir, or biceps, or gastrocnemius muscle.
Deltoid, you're doing upper limb or lower limb?
Sir, in DMD we can do in lower limb, sir.
Lower limb,
Gastrocnemius
what are the
or
muscles? Two muscles.
gastrocnemius, sir, and
Okay.
quadratus muscles.
What is the other thing?
Sir?
What versus lateralis?
Yes, sir.
Okay.
Deltoid is usually avoided for diagnosis of DMD because of the predominant type 1 fibers, 70 to 80% of. So the ideal site for a muscle biopsy is in vastus lateralis.
Vastus lateralis is common. Right.
And you have to be very careful about setting the specimens, frozen specimens, and for immunocytochemistry. So the process of muscle biopsies, we have to be very careful after the obtaining the specimens, because if you delay in processing it, and all the efforts, all the pain the child undergoes will be waste.
Okay.
You told me about the course of the illness.
Yes.
What are the causes of? You said their life was only 2 decades. DMD children, they don't cross second decade. What
Yes.
are the causes of death in a child with DMD?
Sir, respiratory failure, sir,
Yes,
and
respiratory
aspiration
failure,
pneumonia or cardiomyopathy also.
cardiac, intractable cardiac failure, right?
Yes.
And more, there may be due to aspiration also. In later stage of disease, they may develop pharyngeal weakness. Because of it, they can have episodes of aspiration and the nasal regurgitation.
Yes.
Right?
Yes, sir.
Because of the respiratory muscle involvement, they will have frequent pulmonary infections due to ineffective cough. Right?
Yes, sir.
Tell me about other complications of DMD.
Sir, ankle contractures, sir.
Not necessarily ankle. Any joint can be get
Yes, sir.
contractures.
And sir, rhabdomyolysis during anesthesia.
Okay, malignant hyperthermia.
Yes.
Okay. Any CNS complications?
Scoliosis and kyphus, spine deformities.
Yes. Scoliosis is very, very important because it will be as far as the child is ambulant, This scoliosis may not be a big problem, but once a child is bedridden or wheelchair ridden or bedridden, the scoliosis will create its own problem because already the respiratory function is limited. It will further compromise the respiratory function, and it will further cause the cardiac complications also. So scoliosis, once the scoliosis becomes a major player, then the rapid deterioration will be there. Any central nervous
For
system.
easy remembrance. Hello?
Yes, sir.
Sir.
For your easy remembrance, I'll just say the mnemonics A, B, C, D, E. Aspiration, breathing problems, behavior problems, cardiac problems like arrhythmias and cardiomyopathy, congestive cardiac failure, contractures, especially involving ankle, knee, and hip, and deformities like scoliosis, eye problems, cataract, epilepsy, which is more common than general population, feeding problems, failure, cardiac failure or respiratory failure, fatal rhabdomyolysis during anesthesia, and in gastrointestinal tract, smooth muscles can be involved, resulting in acute dilatation of stomach or intestinal pseudo obstruction. So for students can remember easily as A, B, C, D, E, F, G.
Okay, sir.
Yes, sir.
Okay.
You were telling about it's a pure muscle problem, muscle disorder. Why there is going to be a CNS complications like intellectual impairment?
Sir, dystrophin is also present in brain, sir.
Yes, good.
Yes.
What are the muscles involved in hypertrophy, and what are the muscles involved in weakness in DMD in the early stages?
So in early stages, the proximal muscle will be involved in wasting, sir. There will be thinning, sir. The distal muscle will hypertrophy in order to compensate, sir.
No, the hypertrophy is not to compensate the proximal weakness. How will weakness of proximal muscle can be compensated by a distal muscle? What is the cause of hypertrophy here?
Sir,
The deposition of
degeneration and
fat.
fat infiltration.
Fat infiltration and your increased mononuclear cell infiltrations.
Yes.
Right, connective tissue proliferation. That is the cause of hypertrophy, pseudo hypertrophy. It cannot compensate for the weakness of the proximal muscles. What other sites are involved in hypertrophy in DMD?
Sir, deltoid, sir.
Of muscles? No. Tongue is the second
Tongue.
most common, and your supraspinatus.
Okay.
Right. Okay. What is the management? How is it? What treatment? Next.
Sir, treatment is multidisciplinary team approach, sir. We can give physiotherapy, but moderate physiotherapy, sir. Excessive physiotherapy may be a problem for the child, sir. And nutrition, we have to avoid overnutrition because the child is progressively will become less and less ambulatory, sir. If he or she becomes obese, there'll be more problems related to obesity, sir. And adequate calcium intake, sir. Steroid can slow down the progression, sir. It has been proven in some studies. Steroids can slow down progression, and we have to maintain ambulation as long as possible, sir. If there is any complication, we have to treat, sir. If there is a lower respiratory tract infection, we can give antibiotic. If there is congestive cardiac failure, we can give diuretics. And as prophylaxis, we can give immunization also for respiratory infection. And we can do regular cardiac monitoring for detecting cardiomyopathies early.
And management of you have to include management of cardiac failure also.
Yes, sir.
Because this dilated cardiomyopathy, they respond well to digoxin and AC inhibitors, right?
Yes.
This regular cardiac monitoring means 2 years in the first decade,
Once
every
for
2 years in the first decade, and every year in the second decade. And physiotherapy, already the child will be using most of their muscle reserve. So physiotherapy is not helpful in going to further strengthening of muscles, but in some extent they can prevent contractures overzealous physiotherapy is detrimental for it will fasten the degradation of muscles. And the nutrition, adequate calcium intake should be maintained, because once the child become immobilized, osteoporosis will be set in. So adequate calcium intake is very important. And once the child is immobilized, in two ways, he can go for depression, and overeating can be there, rapid weight gain will be there, and he cannot burn more calories because of the immobility. So nutrition, we have to be very, very careful. Once the child becomes obese, already his muscle weakness, it will exaggerate the existing muscle problems. And the steroids, you can be more specific. Prednisolone 0.7 milligram per kg per day for the first 10 days of the month. We have to be very careful in avoiding the side effects of the steroid therapy also, because it cause its own myopathy. Deflasocort is also found to be very useful. The one caveat in steroid uses, you have to avoid using fluorinated steroids like dexamethasone and triamcinolone, which can cause more muscle problems, myotubular ceramide accumulation in myotubules. The most important part is maintaining ambulation as long as possible, even if it is for 1 hour a day. Till you are maintaining this ambulation, we can manage the child relatively better. Once the ambulation is lost, then the child will be going the downhill course very, very fast, right? This ambulation is not only important for DMD children, the ambulation is very, very important for even our own normal, for you, for me, for all the adults. Recent studies have proven that more you strengthen your lower limbs, it's directly correlated with the longevity of your life. And we already know most of your cardiac strengthening exercise are more of aerobic nature. So walking, jogging, swim, everything, it will directly help to have a healthy heart. It's also good for brain, for prevention of depression, and increase the cognitive capacity and problem solving abilities has been proven in adults who undertake regular walking. So it's very important for you also to maintain ambulation, to increase the use of your lower limbs. Paradoxically, the medical education system itself is causing more and more sitting oriented classrooms, because starting from 8th standard, you all will be memorizing everything. You will be working hard, studying hard, sitting and studying for the 10th exam, for the +2 exam. And after you enter the medical college also, you will be made to sit for hours together, 1 hour lecture class, 1 hour like that. So in the medical education system itself, there has to be some change, because we have to make, before preaching others, we have to follow. Every 20 minutes, if you are going to be in the sitting posture for more than 20 minutes, it is like you are having a cigarette. So sitting is the next smoking. So students should take care of the sitting time. Like screen time, sitting time is also very, very important. It's dangerous to your heart, dangerous. It will create its own metabolic problems. And immunization, apart from the routine immunization, flu immunization is also very important, because any milder a flu infection can cause mild problem in a 10-year-old child, a normal child. But in a child with DMD, already his respiratory function is under the borderline. In the borderline, a mild flu infection will cause a rapid deterioration of the respiratory function. And we can do periodic pulmonary function tests also, right?
Yes, sir.
Any new treatment, any newer therapies?
Sir,
Sarg has given
molecular
the
alteration can be done, sir. Genetic engineering, genetic therapy, gene therapy.
gene therapy.
Yes, sir.
So
And
mainly the problem is in the exons. Sarg have mentioned
sir.
here in the chat. Everybody has seen exon skipping is the new therapy, gene therapy, viral mediated plasmids. Any drugs for any drugs?
Givinostat histone modifiers.
Drisalispan and etilipsin. These are exon skipping antisense oligonucleotide drugs.
Yes, sir.
And they will somewhat increase the production of dystrophin, so thereby prolonging the ambulatory time.
Okay.
Next slide. So this is how the dystrophin is a supporting structure for the muscle membrane called sarcolemma. It's a link between the actin and myosin actin and the membrane, muscle membrane. Once the dystrophin is destroyed, the sarcolemma becomes very fragile and it will cause muscle damage, and there can be functional ischemia, and everything go towards muscle, exaggerating the muscle damage, and they can cause coagulation abnormalities also. Right? Next slide.
Yes, sir.
The common clinical presentation in a child with DMD, this all your weaknesses of the proximal muscles with pseudohypertrophy of the calf muscles, weakness of dorsiflexion, and weakness of shoulder abduction and extensors, protuberant belly, lordotic posture with the Trendelenburg gait. Right? So it's very clinically this is most common neuromuscular disorder, DMD. So you can easily diagnose DMD, but the thing is confirmatory test, and you can do it in a programmed manner, step-based manner. The more important thing is the management of the child, his own behavioral support and psychological counseling, and the counseling of the family. If you diagnose DMD successfully at your diagnosis is correct at 4 years, what are you going to tell the family? That he will die at 14 years, right? You are going to say the child will live only for 10 more years. So everyone is going to die, but we don't know when we are going to die. That's but in a child with 4 years, you are doing tell ஒரு 10 வருஷம் தான் இருப்பான் பையன், கொஞ்சம் கொஞ்சமா நடக்க மாட்டான், அப்புறமேட்டு வீல் சேர்ல உட்காந்துருக்கணும், தள்ளிட்டு தான் போகணும், அப்புறமேட்டு படுத்த படுக்கையாயிருவான். So it's a very difficult situation for the family. So we have to explain them. Maybe in the next decade we can expect some very good curative therapy, either from the stem cell therapy or from the gene repairing. We can expect some curative therapy for DMD, and so we have to take care of the family also. And you said this is a first pregnancy for this mother, this
Yes,
case
sir.
you presented.
Yes,
What
sir.
precautions you will take when the mother gets conceived, is planning for the next child?
Sir, prenatal diagnosis. I can try for prenatal diagnosis, sir.
Before that, we can see whether the mother is a carrier or not.
Yes, sir.
Oh, so
Carrier
if the
state
mother
of the
is not
mother.
a carrier, then we need not worry that much, right?
Yes, sir.
If it is if she is a carrier, then we have to be extra more vigilant in the prenatal period, right? How will you make the prenatal diagnosis?
Sir, chorionic villus sampling can be done, sir.
What will you identify?
Amniocentesis, sir.
What will you identify? This is same as your PCR test, right?
Yes, sir.
So or you can use southern blot analysis to look for the XP21 locus differentials, the problems, right? So prenatal diagnosis is possible. If there is a family history of DMD, you can do prenatal diagnosis, and if the mother is a carrier, then you can do the prenatal diagnosis for the first child itself, or else for the sibling of the DMD child, you can always go for the prenatal diagnosis, and we can confirm the presence or absence of the DMD. Right?
Yes, sir.
Sir, any questions? Sir, is there a time?
15 minutes, more 15 minutes more.
Yes, sir.
One more point I want to add here.
Yes, sir.
Actually, they have tried myoblast transfer therapy. Actually, the myoblast from the father or a close relative, preferably father. If it is normal, it can be taken and cultured in vitro. And this myoblast, cultured myoblast can be injected into the calf muscles. This will produce dystrophin, and these cells will replace the abnormal cells. And there is a possibility produce dystrophin. So it is like stem cell therapy, and it's under trial. So another mechanism is retrovirus, which can be used as a vector for dystrophin, normal gene. The retrovirus, when it's injected, it will go into the body and multiply, and the incorporated gene, dystrophin gene, will replace the abnormal genes in the muscles. So these two studies are under trial, and maybe it can become successful because retrovirus is going to infect all the cells. So the cells which is having abnormal producing cells can be replaced by these cells. So these two are under trial: myoblast transfer therapy and retrovirus therapy. Of course, it is like stem cell therapy. Maybe in the near future, it can become successful. Thank you.
Next slide. So any child presenting with a weakness, which is a neurological weakness, first step you have to check whether it's an upper motor neuron type or a lower motor neuron type. When we entire undergraduate, I have spent memorizing the differential between upper motor neuron lesion and the lower motor neuron lesion without realizing what is an upper motor neuron and what is a lower motor neuron. So if you understand the anatomy, neuroanatomy of upper motor neuron, lower motor neuron, it will be very easy to diagnose cases like DMD. So in a lower motor neuron, everyone is there using a laptop. In the last 1 year, online classes have been very, it have become very common mode of taking teaching. So for example, if you are switching on your laptop and it is not getting started, then what will you do? You change the socket. So you will put in another plug, and again if you switch on, if the laptop is getting started, the first scenario the problem is in the socket, right? In the second scenario, the laptop is not getting started with your power cord, but if you use your friend's power cord, the laptop is getting started. Then it means the problem is in the power cord. So if your laptop is getting started, not getting started without a battery support, so it is working well when it is connected to the power connection, but it is not working when the power connection is switched off. That means your problem is in your battery. So the same applies to the lower motor neuron. You have specific characteristics for each and every domain of the lower motor neuron. Lower motor neuron starts from your anterior horn cell. This anterior horn cell is the power socket for your laptop, and your muscle is your laptop. You can have a comparison. So the problem can be in an anterior horn cell, or the radicals, or the nerve, or the neuromuscular junction. Just the point where you insert the power cord into your laptop. That can be compared with the neuromuscular junction or the muscle. So you have made a very detailed a chart on the sensory involvement. It is very, very important in a case of neuromuscular weakness, because if there is no sensory involvement, then only two of these domains are ruled out: radicals and nerve. If there is no sensory involvement, it cannot be a nerve problem. It can be not be a radicular problem. Anterior horn cell, neuromuscular junction, and muscle, there is no sensory component at all. So among these three, neuromuscular junction, as you said, example of myasthenia, it's a fatigability. morning the child will be better, the weakness will progress to the evening. And doing the repeated actions, the weakness will manifest. So fatigability is a classical feature of neuromuscular disorders, and it involves all the muscles, skeletal muscles in the body, and more predilection for the facial muscles, extraocular muscles, like that. So neuromuscular junction. In a muscle disorder, it is again all the skeletal muscles will be involved, but some muscles will be more involved in the earlier stage. Then eventually all muscles will get involved. In myopathies, proximal muscle weakness is more than the distal muscle involvement. Proximal muscle weakness is there, no sensory involvement at all. Deep tendon reflexes will be present or diminished. So you cannot, in lower motor neuron lesion, you can never get an exaggerated deep tendon reflexes. That's why Sar was mentioning about your grading for that ankle jerk. So you can still elicit a deep tendon reflex in a muscle myopathy or a muscular dystrophy. In anterior horn cell, deep tendon reflexes is totally absent. Areflexia is the characteristic feature of your anterior horn cell involvement, and there's no sensory involvement, and fasciculations are very common in anterior horn cell involvement. In a genetic disease, you can the example for an anterior horn cell involvement is your spinal muscular atrophy or Wendig-Hoffmann disease. In an acute infection, poliomyelitis is a common example for your anterior horn cell involvement. So deep tendon reflexes, that's why sensory system and the presence or absence of deep tendon reflexes is very important to classify this illness in the lower motor neuron. If there is sensory involvement, muscle diagnosis is ruled out, neuromuscular is ruled out, and anterior horn cell is ruled out. If there is sensory involvement along with the weakness, either it is going to be a nerve problem or is going to be a radicular problem. How will you further differentiate? You have to map the sensory involvement. If there is a dermatomal pattern of sensory involvement, then the radical is affected. And most of the problems with the radical disease like a GBS, it's a it's not a chronic problem. It will be a subacute problems. If the sensory involvement along with the motor involvement, the sensory involvement is a neuropathic pattern, what you call it as a glove and stocking pattern. The entire area supplied by that nerve is involved, then you can easily diagnose a neuropathic problem, neuropathy. So then you can go for the differential diagnosis of the neuropathy, depending upon the clinical presentation. Sar told about your lead poisoning. So it's very common. So you cannot miss out. If it is a neuropathy, you have to test the serum lead levels. So whatever be your grade, you may be an MBBS student or an pediatrics PG or a neurology PG or a DM neurologist, whatever be the position, in neurological examination, you have to examine the child as if you are examining in the final year examination. So detailed examination will give you correct clues to the diagnosis, and depending upon the history, you can arrive at the diagnosis very, very confidently. You cannot skip anything. In neurology, you cannot skip anything. You said calf muscle hypertrophy. It's just because the calf muscle is big, we cannot assume it has more power. So here, in spite of being enlarged calf muscles, there is weakness. Just because the proximal muscles are wasted and thin and weak, you cannot assume distal muscles will all be like that. Your ankle jerk is spared, but knee jerk is absent. So just because knee jerk is absent, you cannot skip the ankle jerk test. Each and every step is important in neurology, and also the symmetry. Just because there is absent exaggerated deep tendon reflexes on one side, you cannot assume the left side will also the same. So you have to compare the both sides. So be it a sensory mapping or a deep tendon reflexes elicitation, you have to make it, you have to do it for all the joints, all the as you study in a final year, you have to do it in all the time, and also for the both and right and left. Without this, you may not be able to arrive at a diagnosis, right? So the lower motor neuron starts from in a spinal nerve. The lower motor neuron starts from the anterior horn cell, and everything below the from the anterior horn cell is a lower motor neuron, and anything above the anterior horn cell is the upper motor neuron. In a cranial nerve, there is a cranial nerve nucleus. So anything below from the nucleus and below, it is a lower motor neuron, and anything above the cranial nerve nucleus is an upper motor neuron. Lower motor neuron, once you make this broad difference, upper motor neuron lesion or a lower motor neuron lesion, and you can easily go into the diagnosis. Without this basic classification, you cannot arrive at a diagnosis in neuromuscular, especially in a neuromuscular weakness. And more importance of testing the extraocular muscles and facial muscles and pharyngeal muscles, because pharyngeal muscle weakness is directly related with the risk of aspiration. So in all cases of weakness, all cases of neurological involvement, you have to purposefully test for the gag reflex and the presence of pooling of secretions in the throat, because it is an immediate risk. If it is a GBS, there are treatments are available if you diagnose early, but if you don't identify the pharyngeal bulbar weakness, child may die of aspiration. While the child may be easy, there is a very good chance of recovery with IVIG, right? So approach is a systematic way. Neurological should be very easy to arrive at closer to the diagnosis.
Yes, sir.
Sir, any more points to add, sir? Sir, shall we end the class, sir?
Dr. Archami, Dr. Lakshman Swami, sir. Unmute பண்ணுங்க, unmute. So unmute பண்ணுங்க, sir. Dr. Lakshman Swami, sir, unmute பண்ணுங்க, unmute பண்ணுங்க. உங்களுது ஸ்பீக்கர் ஆன் பண்ணுங்க.
சொல்லுங்க.
Yeah, any
கேக்குதா?
point you want to add-ங்க? Yeah.
ஹலோ, கேக்குதுங்களா ராஜேந்திரன்?
Yeah, கேக்குதுங்க. Please proceed.
சொல்லுங்க.
Sir, any points you want to add?
ஹலோ.
any points add பண்ண விரும்புறீங்களா?
Thank you, sir.
And small minor things you have to correct, doctor. That's all. I felt it was okay.
Yes.
And Muralidharan sir, thank you, sir. Thank you for the nice discussion.
Sir, thank you very much. நான் உங்க கிளாஸ் நோட்ஸ் எடுத்து வச்சிருக்கேன் சார். Very important points.
Thank you, sir. Thank you, sir. Thank you,
The
sir.
important thing is
Thank you, Rajendran.
The DMD you have to need one is child counseling, one thing, and another thing is for planning for next child. Now you have to counsel the parents. That's the two things you have to concentrate. Okay. And complications, you have to inform the parents. Subtle way you have to ask. Dr. Muralidharan correctly said, you have to inform them that subtle way only. You can't tell that like textbook wise we can't tell. And 5 year you lie down and 10th year you'll expect, we can't tell the parents, and we have to give more of encouragement. Okay, that's the way you can improve. I think a lot of studies are now coming up with myelofibroblastling. That one thing. Another one is steroid also. Some extent only steroid useful. I think very அளவுக்கு I think it's not coming up. I think in the future maybe a gene therapy may be a big way, maybe. Okay.
Yes, sir.
Yeah. Okay.
Finally, you can add one point: anticipatory guidance.
Yeah.
For any topic, Downs, any topic, add anticipatory guidance. What you have to anticipate, what the parents have to anticipate. When the child will develop cardiomyopathy, all those things, you have to explain to the parents. So, even theory or practicals, you can just add a topic as anticipatory guidance. There is a recent trend. So
Okay.
in this stage also can say anticipatory guidance. What to do before next child, what to expect from the child, what you cannot expect. So all these things you have to give counseling to the parents. So give us area topic is anticipatory guidance. So that will be a question for the PGs also or UGs. Anticipatory guidance in Down syndrome, anticipatory guidance in Duchenne muscular dystrophy, leukemia, like that. So just area topic is anticipatory guidance.
Okay.
So on behalf of IAP TNSC, I thank Dr. Aruchami Lakshman Swami and Dr. Muralidharan and the team that Abhishek has presented very well. And I thank one and all for this wonderful case presentation today. And thank you one and all. Thank you. Thank
It's
you.
also a learning
I
experience
thank
for me also,
Rajendran,
sir.
Muralidharan and all the students. Thank you very much.
Yeah. Okay.
It's a learning
Thank you. Thank
experience
you.
for me also, sir.
No, nice. I think you interacted very well. Thank you. Thank you. Thank you. Thank you.
Thank you. Thank you. Thank you.
Thank you.
Thank you.